Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with JR and Jen Gurney. How are you guys doing today?
Doing good.
Hey, great,
Awesome.
Dennis. You're having us here.
So the reason why I tricked you onto this podcast, we are going to talk about palliative care. And I've listened to you both discuss the topic, so I think this is something that we'll get some really good discussion out of. But just because I've heard from other guys saying I don't introduce the guests frequently enough, JR, if you wouldn't mind starting off, just give us a quick intro.
Sure, I'm J.R. Pickett. I'm an emergency physician and EMS physician in Salt Lake City, Utah, and a battalion surgeon from 2nd Battalion, 19th Special Forces. And I'm one of the cadre for the Ridge Healer program out in West Virginia that is running small footprint surgical and medical resuscitation teams in unconventional warfare exercise.
Hi, good day. My name is Jennifer Gurney. I'm a trauma surgeon and burn surgeon, and I'm the chief of the Joint Trauma System. And I know you just did the disclosure on the PFC podcast. Since we're going to be talking about something that's a little bit of a difficult topic, I just want to say I want to have a disclosure that what I'm going to be expressing are my opinions as a Army surgeon, with 5 years deployed, receiving lots of casualties from medics. This is not the opinion of the Committee on Tactical Combat Casualty Care, the Committee on Surgical Combat Casualty Care. But, I'm in those positions as a JTS chief, but these are my opinions as a Army surgeon.
Yeah, perfect. And that's the way it's always meant to be, is just like, what is it that you think? But today's topic, like you mentioned, it's a little bit, I won't say controversial, but definitely needed, palliative care. And I guess my first question is, should we even be teaching medics palliative care? Like, it's one, such a downer. Two, I don't like losing, so I always want to think about winning. Why should I take my eye off the ball and talk about palliative care? Jen, if you wouldn't mind starting off.
Yeah, so yes, and how does that sound for a non-committal answer? So, we absolutely need to be teaching medics end-of-life care. We, need to be sure that medics have experience with end-of-life issues, with caring for the dying, caring for those with expectant injuries, caring for those who are, will not survive to the next level of care. Yes. No, we should not ever call it palliative care. And here's why I think this. So palliative care, like it or not, it's a hospital specialty. And it is meant for people with end of life or chronic diseases to improve their comfort, their quality of life, their well-being. So if you are a cancer patient, you have palliative care. If you're an MS patient, you might be living for another 20 years, but you're really looking at symptom management, stuff like that. We don't call medics who transfuse blood hematologists. We don't call medics who give TXA endocrinologists. They're doing their job. So palliative care is a specialty that has connotations. And my biggest concern about this, and I'm pretty vocal about it, because I do think that we absolutely need to be teaching end-of-life care. And we need to expose medics to death. A medic shouldn't be seeing someone die for the first time when it's their buddy on the battlefield, or any provider, right? They need to be working in an environment where they have to deal with end-of-life issues and see people die. And a good death is part of a good life. But putting forward that we're going to be doing palliative care on the battlefield is the wrong message, in my opinion. It is, we want to do humane pain management, comfort, care that involves comfort for people who have expectant injuries. Palliative care sends the wrong message. I fear we're going to lose our operational effectiveness. As soldiers, people who are with minor injuries are going to think, I'm going to a role 1 or a role 2, and they're going to put me on a palliative care pathway or an expectant care pathway. And that is the wrong messaging. Survivability must be the goal. Operational effectiveness is the byproduct of what we're able to do with survivability. But death on the battlefield is reality in every past conflict, and it will certainly be a reality in future conflicts. So teaching end-of-life care, yes. Calling it palliative care, I feel pretty strongly it's the wrong message.
Just a quick follow-up, I guess. What would you call it?
End-of-life?
End-of-life care?
Yeah.
Okay.
So those that have expectant, who have expectant injuries, expectant is a triage category, someone with a non-survivable injury. And, you can die of 1,000 paper cuts. Each one of those is a survivable injury. But if you have 1,000, so you can, but if you're going to be, if a casualty is going to die, it's an end of life care, and it needs to be humane, involve pain management, and other symptom management. But, uh, I really am worried that we're moving down this path of like group nihilism because we're so concerned about what's going to be happening on the next battlefield and our ability to manage large volumes of casualties and having the right resources. I've got a lot of thoughts on this, and I'll shut up so JR can talk. But like, we, focusing on battlefield survivability, but understanding that we're going to have a much higher case fatality rate, much higher killed in action and died of wounds rate. So teaching end of life care for those who are at their end of life because they have expectant injuries. I've heard conversations of, well, what if you get someone with a gunshot wound to the abdomen and they're not going to be able to be evacuated for 24 hours. We've got to give them ways to die. I'm like, or give them some antibiotics and see if they can live. I mean, like they might die or they might not die. And so, but giving these like overzealous pathways to expedite death and nobody wants to do that. I know no medic wants to do that, but everything we do, we overdo. Blood, needle decompression, cricothyroidotomies. We know that. We have data for that. So if we start pushing this idea of like, we're not going to be able to do things, so we need to go down this pathway, we are going to be creating so much more moral injury with the thoughts in providers' heads. Man, maybe I should have done something and they would have lived. I tried my hardest and they died is one thing. I did what I could do and they died is one thing. But, I put someone on this palliative pathway or expectant pathway, and maybe, and then the helicopter landed, 40 minutes later and they would have been fine, or we had blood resupply and they would have been fine. So I just think that there's a ripple effect from each one of these decisions, and we have to be very thoughtful about how we train and educate, not just train, but educate on end of life care. It's super important, but we shouldn't be championing this idea of we're going to have medics determine early futility because they might not have resources. Slippery slope decreases operational effectiveness, and in my opinion, will really result in, a huge amount of moral injury.
Yeah, I like the term palliative care because the emphasis is on exactly what Jen's saying about pain control and comfort and anxiety, and we are when we shift into that mode, and I think it does need to be a deliberate shift. That when we've decided, okay, this patient, given the resources we have, is not likely to survive, and we don't know all the unknowns. Say like all of a sudden the sky's clear and medevac is flying again. But they do have to make some decisions with some idea of what the future looks like of the operational environment that they're in, that there are other casualties coming, and we don't have good tools to help the medic predict who will live and who will die. Certainly if you've got brain matter outside of the skull, I think that we can all agree that in a combat environment, even a civilian robust environment, that's not survivable much of the time. And but in that limited resource environment, we are if we say, yeah, just keep trying your hardest, that means expending all of the resources that we have, and could mean in the IWUW setting or highly censored environment that we are accessing resources that may increase our signature, that may result in additional casualties, that may endanger the medical facility itself. So I agree we need to train on palliative care, but one of my core beliefs about palliative care is good nursing care, and good prolonged casualty care is good nursing care. It's this attention to comfort and positioning and respiration and anxiety and so many of these things. So teaching and the interventions to do at that end of life, I don't think that those are exclusive of things that are done to care for the patient in that prolonged casualty care, prolonged field care environment. I think it's a good idea to be training all those all the time anyway. I think where we as physicians and operational unit surgeons can help is providing that decision support, because we have in our training we have equated death with failure. And in our training environments, if you do the right things, the patients live. If you do the wrong things, the patients die. Not that that's necessarily a terrible thing all the time, because you do get a little bit more emotional investment in that failure, helps you to remember the lesson a little bit better. But at the same time, we need to be injecting these cases that do ultimately become futile, so that the medic knows, where do I make that decision? And I think in the distributed nature of the medical assets that we will see in LISCO, but as well as the IW environment, that a lot of these medics are going to have to make a hard decision. As much support as we can give them, as Jen says, for reduction of that moral injury, then the more we can do, the better. We have all seen that, where we make a decision based on this information, and maybe even based on some evidence-based rubrics that helped us with the decision, and ultimately ended up being the wrong decision given nuances of the circumstances. But it was that 90% solution that got us most of the way, and it gives them the confidence to say, all right, I these were all the findings that I had that led me to this place, with this undesirable outcome.
Well, two things that I think that Jared, that I think we agree on, violently, is one is we've got to get rid of this idea that if a casualty dies, that's a failure on the medic part. That is something from listening to medics and from being at training exercises that, if a casualty dies, they failed. Like, that's not the reality. That's not the reality of war. It's not the reality of trauma care. So, that we've got to get rid of that and start having, end of life and death being a part of training, and how to manage death. Everything, and not just managing when the casualty dies, but the mortuary affairs, like part of what do you do with the body? Do you move the body? Like, how do you manage more than one dead body if your unit has to move? I mean, we've got a lot of ethos of leave no soldier behind and all those stuff. So I think that we've got to start incorporating, death not being a failure, and then how to deal with it as a team, and not just how to deal with it like at the immediate time, but then how to talk to the team, how to, recover from that, and how to, do AAR. So that's one thing. The other thing we agree on is that prolonged casualty care is good nursing care. No question about it. And you can't really get that in like the training environment. One thing that we've been foot stomping a lot at the joint trauma system, but that, we say a lot when we speak and stuff, is that you've got to get into clinical practices. Like medics have to be working in ICUs and the burn center, great opportunity to do good nursing care. So we definitely agree on that. It would be great if we could agree on that we've got to come up with this lexicon, right? We've got to come up with a standardized lexicon that we can all say something and we know what we're talking about. Because when I hear palliative care, I think of something totally different from what you described. I think of the specialists that come, into, my personal experience is, I've had family members in palliative care, and then when I was a fellow at Stanford, it was the first time I had seen the palliative care service. And, I remember they do a palliative care fellowship. I remember the palliative care physician came into the ICU at Stanford, and there was an old guy, an 80-year-old guy on the ventilator, post-op day 1 from a liver trisyntectomy. And she said, let's go ahead and put him on comfort care. He's 80, he's on the ventilator. I was like, whoa, 2 days ago, he was sitting in a surgical oncologist's office consenting to be on the ventilator for a week, after care. So even palliative care physicians are sometimes quick to say, this is futile, this is futile. And, but that's a specialty, and palliative care is a multidisciplinary specialty that looks at the quality of life, looks at ensuring that patients are comfortable and that they have good symptom management, whether it's nausea from chemotherapy meds or, pain. So that it's not a battlefield thing. It's a special, like I said, we don't call medics that give transfusion hematologists and then say, we these words matter. And when operational commanders hear that we're training palliative care and practicing palliative care, I just think that that focus on survivability, and yes, we're going to have totally different survivability on the next battlefield, whether it's IW or LISCO, but that it's just not the right term for a battlefield practice. And, end of life care, or we could call it something else, but palliative care, implicit in that term, is people who have chronic conditions, that are. So if we go back to before palliative care was a specialty, it is about palliation of symptoms. But it's a specialty now that is looking at those who will not survive. They have lethal conditions, and that is not our soldiers, sailors, airmen. Our combat casualties, our focus, a laser focus on survivability and operational effectiveness, with the caveat we will not do as well, and we will have a lot more death on the battlefield, especially in LISCO, but also in IW or in, multi-domain isolated operations, dispersed operations, whatever it is, right? We're going to have a different level of survivability. And we've been, the victims of our success for counterinsurgency operations, where we maintained small medical footprints, had rapid evac, tons of, we were rarely resource constrained. We might have been very austere, but we were rarely resource constrained. I can think of one time in, years of deployment that we were like, we had no more walking blood bank blood because we were on a small fob. We had no more blood supply, but we usually had maybe limited resources, but we weren't like what we're talking about for the future. So I think that we've got to change our rubric, change our expectations for what battlefield survivability will look like, and message that. And we have been. We've been messaging it so much that there's this enthusiasm for early futility that is really concerning to me, that we're going to, and we're putting the burden on those with the lowest amount of training, the lowest amount of experience. Uh, so 4 years of medical school, 6 years of residency, 2 years of fellowship. I can't determine futility all the time in the first hour. Sometimes you can, like the guy with the brain matter hanging out, but not always. You can't determine futility. So we're asking, especially early on with these kind of expectant care and palliative care algorithms, for medics to determine early futility when we know that that's really hard to do. And I just want to say one more thing, and is that if I had a nickel for every medic over, my deployments, who would, they come back, they'd be bringing the next set of casualties in. They'd come back and they'd say, "Hey, how did so and so do?" Or "How did that guy do?" Or "How did And I'd say, "Yeah, they did fine. We operated on them. We sent them to the roll 3." And they're like, "They lived? I thought that guy was going to die. I was sure he was going to die. We almost didn't do this because he was going to die." Those would all be casualties that very early on the medics would put on a quote unquote palliative care pathway because they think they're going to die. And it's just not. And so, I've just heard that over and over again, the surprise that some of these guys with really bad wounds lived. And so I just don't think we should put that burden on the medic. I think that, we do, and I got it about, electronic footprint. There might not always be telemed. Look, we've got to also rely on advances on the battlefield to help hide electronic footprints, to hide signatures, other jamming things. I mean, there's other work going on that will be able to help us. We are not the biggest electronic footprint out there. What the medical is. Yes, we have signature footprints, which is concerning, but we can't. I think that our focus, and yes, JR, I wrote it down. You said decisions in the operational environment you're in. We always have to take into the operational and tactical environments that we're in. But if we fuck this up, excuse my language, but if we are really kind of focused on palliative care over survivability, you'll have a strategic impact. So yes, agree with operational and tactical environments, agree with decreased survivability, absolutely need tools for end-of-life care, pain management, all that stuff. But we've got to take our strategic impact into effect as a medical community with what we kind of message. So I would love it if we could, kind of say, all right, we agree that medics need end of life care training, and I just but palliative care is it's not I just don't think it's the right term. And I know I'm probably in the minority of people that say this, but we have to think about that context and what that message is.
Yeah. I mean, if you guys don't mind, like, I do not care what you call it, because I think it's a lot like the nursing care. I can teach guys for days how to do, like, fill in the blank, but to get them to actually make the decision to do it is super rare, and we'll go hours. And I'll point out, hey, did you notice that your patient is like laying on a 20cc syringe like for hours? Maybe that's why he's been moving around, right? Or, if why does he have red rectangles on his chest? Like, oh, because you put the heating element directly on his skin. I think the actual problem in this whole entire situation is triage, like just getting to the decision of how do I sort these patients out, who can handle themselves, who do I need to intervene on, and who I would love to help, but I just can't. And I think that's the major problem. Jen, when you were downrange in GWAT, how many urgent surgical patients did you get that walked off the helicopter and
Yeah, triage is hard. We get it in the trauma bay here too. I mean, in the burn center with everything, triage is really hard. And there's dozens. I think between JR and I, we could probably name 30, projects at the local, regional, or national level that are looking at better, triage algorithms and how we can, use AI, to stuff for triage. Triage is absolutely key. You're right. I mean, triage is key, but the most important thing about triage is retriage, you know, and because somebody that, so um, somebody that's urgent surgical might become a delayed patient, or somebody that's immediate might become a delayed patient if they get hemorrhage control or if they get a unit of blood, just like the expectant patient. The expectant patient might all of a suddenly be an immediate patient, or they might be a dead patient. I mean, like it just so that retriage is absolutely essential. And there are plenty of stories and we all have them that we've triaged patients as expectant and in multiple casualty incidents, and then 2 hours later, like, heck, he's still alive. Well, let's give him some blood and get him a scan and take him to the OR, or, they're sitting with the chaplain and a couple of their unit guys and they're dying a humane death. And the guys that are dying, and this is going to sound really harsh, and it's not meant to, but it's the reality of death. Um, you know,
Yeah.
someone who's dying, and JR, this, like someone who's dying from hemorrhage or severe TBI, they're not really aware of what's going on. The TBI patient, guppy breathing, and they're like it's very uncomfortable to be around them because if their reticular activating system is triggering them to breathe and the way that their breathing pattern is, but they're not in pain. We give them pain medicine. We do that because it's a humane thing to do. But I mean, guys that are dying of hemorrhage, we do horrible things to them. We put tubes down their throat, we crack their chest, we put a clamp on their aorta, we staple off parts of their lungs, we open their pericardium, we put stitches in their heart, we do all sorts of stuff. If they survive that, they have no memory of it at all. So, the guys that are immediately dying, the truly expectant from like bad injuries, they're not suffering like we think they are. We don't need to expend a ton of resources on them. And I'm not trying to sound like an asshole saying that. It's just true. Like someone who's dying now, the burn patient, uh, with a 80%, partial thickness burn or even full thickness burn where they don't have pain, but they're very, very aware. Yes, they need a lot of pain medication. And this is the stuff we have to get into training. And I think that getting into training scenarios, and we need to work on modeling different scenarios for who's going to die at 4, 6, 8 hours. We have data that most people who are going to die in the first 90 minutes of trauma, which is why TC3 and blood transfusion and all that stuff, moving it closer to the, point of need. But those that are going to die at 4 to 6 to 8 hours, I don't know if we've totally defined that population. We know the TBI population, but the rest of it, we probably need to do some modeling and continue to work with the data that we have to be able to inform, how medics and pre-hospital providers take care of those patients. This is not an easy problem. If it was easy, they'd do it at Walmart, right? This is like not a, this is challenging, and triage has been a challenge since it was first described by Napoleon surgeon Leray, 250 plus years ago. And so I think we have to continue to get better at it. But I just think we have to be careful about determining futility too early and expediting death, which is what I fear, and others as well. I'm not the only one who feels like this, but that if we determine futility too early and expedite death, that there are going to be those with survivable injuries who go on a pathway and they don't make it back to their families. They go home in body bags instead of go home on a medevac. Right.
But I hear what you're saying about palliative care, and I agree because it is its own specialty. What else could we call it? Can we call it comfort management training? So, which would apply to the dying patient as well as the living patient and the prolonged field care patient. And I think, but where do we draw that line? If you're talking an ODA that has 4 units of blood and a walking blood bank that maybe represents an additional 8 units, then and they know that, okay, if we expend this, then the next casualty that comes in, which in certain environments we can expect is absolutely going to happen, then we've got nothing for them. And are there indicators early that that can help with that tough decision of, hey, we're not gonna burn this resource anymore, which is a terrible thing on an individual level, to say, all right, this could be a potentially survivable injury. And I think about the end of the movie The Mist. That Stephen King's short story that where, say it's Thomas Jane that has his family taking him out into the mist, and then all the creatures and everything. He's worried that they're gonna die, and if anybody hasn't seen it and they're going to see it, I'm going to ruin it for you right now, but here you go. So he sees like shadows in the mist, thinks the creatures are coming to eat them, and so he kills his family, and then realizes it's the army and they've showed up to rescue them. And this is terrible, terrible decision.
I probably never will, but that's a really good analogy.
Um,
But
yeah, and that's an awful feeling, and especially on an individual level, it's an awful feeling, and um, but with these small footprint distributed medical resources that are not going to be able to have the logistics because every aircraft's getting splashed, that's every vehicle that would bring them their blood resupply is getting splashed, and you've got only this much, then I know it feels good to like burn all the resources, say we did everything to try to help this guy, but now our team can't operate, and now we can't. And what saves lives on the battlefield? It's tactical superiority. It's having control of the battlefield and aggressiveness. I don't want to look at the ODA commander and say, okay, look, you can assault this, but just understand we have no blood, and that any significant injury is not something we are going to be able to resuscitate beyond what we're doing, what I was doing as a paramedic in the mid 1990s, no, which is crystalloid and hopes and dreams. But I absolutely hear the palliative piece, and I think there's two different pieces here that we're talking about. One is palliation of pain at the end of life, and the other is expediting death. And I'm with you. I am not at all like I'm not pushing a big slug of rocky rhonium to send somebody off to their maker. I think that is
that would
uh,
be a bad death because they would be aware. But yes,
well, yeah, yeah, they'll be waiting for me in hell
right.
to take that up with me. Um, so, but I think that making that decision for accelerating death, I don't think that's something that we can do as providers. It's a
But it will
different
happen.
story when the
It will
patient does.
happen. That's the thing, is that's the everything we do, we overdo. And I think that those algorithms, would happen. But, so JR, a couple things that you said. So if I could just, Dennis, I'm sure you have more questions. I just wanted to address a couple things that JR said. Is that, one is truth to commanders. We've got to tell the commanders the truth of what our capabilities are, because a small ODA without a surgical capability, and that's out in the middle, 4th Battalion out in the middle of nowhere, that doesn't have a local hospital that they can leverage, or doesn't have an operational, kind of context, they're going to be in trouble. They're going to be in trouble, and their risk is high. And they know that, and their commanders need to know that. So messaging, the truth, and not saying that we can save everybody's life in certain situations. So I think that, being able to be very honest about our capabilities, and you and I both know that many, command surgeons over the years will say, yeah, we got this, we can do this. And that's not always true. So I think that, being transparent about what the capabilities are, because they are in this with us. So, like, if an ODA, or what people say, the scenario we get, well, the roll one has 2 units of blood and 30 casualties. Well, why the heck does a roll one only have 2 units of blood? Why haven't we optimized our trauma system? Why haven't we understood that the most life-saving capability that we have data for, 3 things that save lives that are data-driven, uh, hemorrhage control. So, tourniquets, surgical hemorrhage control, blood transfusion, and there's more data for blood transfusion than any of these, and time to capability. So diesel, blood, hemorrhage control, right? And so if we haven't optimized our system, or if we can't optimize our system, if we're losing the next war, it's also the commander's responsibility. And we have to message that we're, this is what we need to optimize the trauma system. And the other thing you said, and I hear this all the time, and it's hard for me to, like, you know, not sound like a ivory tower surgeon. Yes, I do, work at a MTF, and I have deployed to a roll three, roll threes multiple times. But most of my deployments have been in the roll two environment, and we are small teams. And this idea of, what if we get somebody next? Well, what if we use all our resources and we get somebody next? And, when we do training, and and in real life, you got to take care of the patient in front of you. Yes, it might suck to be the third patient of a mass cal if you're, if you're running low on resources, but, like, and I'm not saying expend everything, on every patient, because we just won't have those resources. But this idea of, I have one really sick patient now. Yeah, I can take care of him, but what if I get somebody? Well, yeah, but what if you don't get somebody? And so I just think, and these are the hard things. None of us have a crystal ball, but we owe it to the service members to take care of the patient in front of us. And then this is where I go back to the trauma system. If our trauma system is unable to be optimized because the drone threat, we're losing the war, it's our responsibility, but it's also the operational commander's responsibility. And we have to message, we don't have an optimized trauma system, and we need this to do it. Now, will it work out? No, not all the time, but sometimes it will. And this is the other thing that we are really focused on training, walking blood bank training, because, a small ODA, yeah, they'll run out of donors, but they're never, like, I mean, if they're totally isolated, the example that was always used to be given to me, what if there's just 4 guys and they're in Africa, and one of the guys gets an elephant tusk to his abdomen through his aorta? We need to train our medics. I'm like, no, you need to give that, like, if that guy got an elephant tusk through his aorta, he's going to die. Like we have to recalibrate, like, what is, I think we're saying the same. We got to recalibrate about what we can do and what death is. But I just, determining futility early, and saying, like, well, we could take care of this guy, but, and I think those are the thresholds we have to come up with. So, you've got the gunshot wound to the chest or abdomen, or blast injury, fragment injury to chest or abdomen. Okay, you have 6 units of blood. You're working to get more. You give them 2 units and you see what happens. And if they are a complete non-responder, then, maybe the algorithm is you don't give them any more blood, or you give them one more unit. And if they die, they die. But we have to, our patients need to know that we're going to try, like that we're not going to put them on these early futility pathways. And, you know, and sorry, I know I'm talking too much, but in 2011 in Helmand province, the guys used to preposition tourniquets on their thighs before they'd go out on mission. This was when cordon and Knox operations were going on, and so many guys were getting dismounted complex blast injuries and getting their legs blown off. So they'd preposition tourniquets, knowing that their buddy would tighten those tourniquets down and they would survive. The My concern is that the impact of this messaging of determination of early futility and role ones, pre-hospital providers, role ones and role twos going down these rapid pathways of expecting care is they're not going to preposition tourniquets. They're going to put signs on their chest, "Do not take me to medical care," because I have just as good of a chance of surviving with nothing as opposed to going to a medical treatment facility or getting taken care of by a pre-hospital provider that's going to put me on a pathway that ensures I will not make it home. I'll take my chances. That we have to be aware that that is messaging, and we all know that over the years we have done heroic medical procedures on casualties that we knew 98 to 90% chance would not survive, and we did that because the units needed to know that we would do everything we could to get somebody back to their family. We will lose that. is it'll be much quicker to lose than it did to gain the trust of the operational force.
Yeah, I think well, I think you bring up a lot of great points with this, and we don't want to damage the trust that they have in us. And I don't necessarily think that we should just say, "Oh yeah, you've got a lot of shrapnel in you, and we should not do anything." I think that what you suggested there about seeing who's responding to care and who's not is a big piece of it because as if you dump 2 units or 4 units, and I don't even know what that number is necessarily. It's going to depend on environment. To your FRSD, which has 80 units of blood, then we've got a bit more leeway. But seeing and that's such an important piece of that battlefield care is the trending of vital signs. Which way is this patient going? And I think that is something that we are now doing a little bit better job of teaching in prolonged casualty care, and I think is important too for that. Um, I hate to say determination of early pathway, but figuring out, okay, how much sunk costs are we going to continue with this casualty? Um, we uh, I think too that even our non-medical brethren understand when we're doing stuff that is futile, and if they see us dump all these resources into this guy, and then the next guy comes in, and we've got nothing left, and they're also wondering, well, man, we just burned all this stuff on this guy just to make a show of it, and now we didn't have anything for this other dude that might have been saved.
Yeah,
Then
that
that's
to just say that we know that what we do medically impacts the operational force. Right? You and I are on the same page with that for sure. Yeah.
100%. Um, and I think too, what the work that Dennis is doing in getting this message out, and you and I are doing, is this all has to be part of the conversation. That
Under
when we're training our medics, that understand death is a part of this. That it is so important for us to wrap our minds around that fact, and for us to understand too, there are patients that if this patient has suffered this injury right now outside of your hospital, and Dr. Gurney was. I'm looking up at from the trauma bay, and Dr. Gurney is standing over me. I have total confidence, like I will survive. That'll happen. But put a few hours between me and that point, and or put a few hundred other guys at that door with similar types of injuries, then it's that the chances of me surviving goes way down. And as the medical providers, the commander can't make that decision. We have to help them and understand that. As we know, expectant is not just the patient's going to die. The expectant patient is the one who, given the resources we have available to us in the environment that we are in, is not likely to survive.
I think if we could, really work on a lexicon for all those terms, like, and end of life care. What is end of life care? It's care of the expectant. What is the expectant? Someone who has a non-survivable injury, or someone who has a non-survivable injury in that environment. Like I said, you could die of 1,000 paper cuts, and that, and if you have no, if you have no blood, no medical care, no nothing, you will die of 1,000 paper cuts out. And so it's just we have to reframe this. We have to. I think we agree that we have to get end of life care and death into medic training. They have to be comfortable with, nobody's comfortable with it, but, with managing the expectant patient, to expect the casualty who doesn't have survivable injuries. And then where does the expectant definition kind of change when it's driven by resources, and how do you allocate resources? I think we have a lot of work to do with this, and, but it, the other, thing I think we have to say is be sure people know that a good death is part of a good life. And that if someone has lethal or near lethal injuries, we don't want them to die in pain. We don't want them to die, alone. That's why chaplains, I think, have been a crucial part of care. And, what were some of the stuff we're learning from Ukraine about the things that they're doing to ensure that those with non-survivable injuries get compassionate care. What we call it, I don't know, but I don't think it should be palliative care. It's the wrong message, and it's not what we do. These are not people with chronic disease, and, and are destined to death. They're triaged as expectant. They're likely going to die, but they might not if resources change, or if the tactical or operational environment changes, or if we got it wrong. Like, and we get it wrong. Even we get it wrong. And we do this, as a living. We're not in the motor pool, and then, medics on when we're doing training and when we deploy. Like, this is our job. And we still can't determine early futility. It's so hard. And I think that putting this burden, this is where we need to really come up with better triage tools. Putting this burden on the medic is is the least amount of experience, smallest time to train, and having them make these decisions, especially if especially we are telling them you're gonna have to make this decision early and put someone on one of these pathways. Like, you know, I don't know. I think that's gonna more moral injury if they put someone on this expectant pathway, and then they find out later that, this was a totally survival injury. One of the things that's helped me a lot, and I would put this out there, I'm gonna put this on the podcast because we'll do this. We do military trauma mortality reviews on every US service member. We look at their pre-hospital care, we look at their autopsy, their postmortem CT scan, and we determine survivability. One of the things that's helped me for the casualties that I've lost, and the first couple times I asked, I was didn't want to ask because I almost didn't want to know, but like, hey, this guy that died on my OR table, what did the military trauma mortality review, what did it show? And when they have a non-survivable injury, it's a very feeling. You're like, okay, well, there's, the review board said that this was not a survivable injury. Now, does that mean we shouldn't have tried in that circumstance? No, because I didn't know it was a non-survivable injury. It told me, so anyway, and so people, the casualties that kind of haunt us, uh, I, our our providers from medic on up can find out if the casualties undergone the military trauma mortality review, if they had survivable and non-survivable injuries. We learn a lot from these deaths too. We learn about how to optimize our trauma system, and how to get better, and how to bring capabilities and tools closer to the point of need to improve survivability. And I just think that needs to be our message. Our goal is survivability, survivability and supporting the operational force. We go where they go for a reason. And yeah, LISCO, IW, EW, survivability is going to go way down 100%. And we got to be honest about that. But that doesn't mean we're not going to do everything we can to optimize that. And when we can't, then a good death is part of a good life.
I think as the unit docs, I think our function too, and our duty to our medics is to look at those cases and put a hand on their shoulder and say, man, like,
Totally.
given everything that happened, give everything that you had, what you had available to you, what you knew at the time, you made the right call. And that matters a great deal to the medics coming from the docs, to say, you know what, this was not a mistake. This is part of this whole milieu of all the different conditions we have to deal with. And I encourage all the docs who are watching this to never give up that responsibility to the medics. That word right there will it will hopefully keep the 9mm out of their mouth, or the bourbon out of their mouth, and before they get behind the wheel or something like that. Just so important to support our folks.
100%.
Absolutely. Well, again, hey, thank you guys very much. I really appreciate it.
Thanks
Yeah.
so much, Dennis. Great to be here.
JR, it's good to talk to you. I think we see more eye to eye on this. We're more similar than different. And I thought your last comments were really important. Dennis, thanks for inviting us.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.